Says we're going.
It says so.
All right. Well, good evening, everyone, and thank you for joining us tonight. My name is Sarah. I am the Director of Community Relations here at Primary Body Works, and I'm going to be your moderator for tonight's event. Tonight we will be discussing back pain, but specifically low back pain. And to start, Dr. Tyner will give a brief overview of back pain. And then next we're going to move into how Primary Body Works clinically proven proprietary treatment can help put an end to your suffering. At the end of that, we will have a questions and answers segment, but feel free to just send us your questions at any point during the seminar. And with that out of the way, it is my pleasure to introduce to you Primary Body Works Chief Medical Officer, Dr. Michael Tyner. Thanks for being here, Dr. Tyner.
All right.
So let's talk about back pain.
All right. First of all, Chief Medical Officer here at Primary Body Works, and my background is general surgery, which really doesn't have much to do with back pain, but the way I got introduced to how acoustic wave therapy can be effective for pain relief is through the fact that I was suffering from back pain. And so I have some personal experience with how this can be effective, and I'll go into that a little bit and then explain sort of how I got involved from a medical perspective in this business. But I was a surgeon, and I was a surgeon for 30 years, and as part of my practice, I began taking on more and more complicated cases sort of towards the end of my career, and I stopped about 2 years ago. Some of my operations, it wouldn't be uncommon for me to be in the operating room for about 8 hours, and a lot of that was spent with a laparoscope, and which meant bent over a good bit. And because I was a little over dedicated, I really didn't take care of myself in terms of exercising on a regular basis. I spent a little bit too much time in the hospital, to make it a long story short. But throughout all that time, I've had issues off and on with low back pain. And then when I stopped being a surgeon, I actually spent a good while trying to back fill, or in essence create a paper related to some topics that I'd spent a lot of time working on. And in doing that, I spent 3 months at a computer, and my back really deteriorated. And I was in significant pain, had heating pad at my bed, ice packs in my car, all kinds of topical therapy, pressure relief therapy with foam rollers and different kind of rolling ideas. I had a trainer, a physical therapist, and a massage therapist. And despite all of that, I still was having pain. And the, I'd say, coup de grace was that I was on vacation in Jamaica, and I got so bad that I couldn't get out of the bed in the hotel room, and have somebody, a physician from Jamaica who I didn't know, come and load me up with steroids and muscle relaxants, just so I could get on an airplane to get back here to the States. And it was at that time that I ran into Dr. Bruce, who had acquired some machinery to provide acoustic wave therapy, and he used it on me. And I was really surprised to find that despite all the other things I was trying, that this technology was helpful. And I was partially the first time I used it, and I was being stubborn, as typical for me. And I thought I could still manage it. And ultimately, between my being pig-headed, 3 sessions with this acoustic wave therapy was enough to get me so that I wasn't in pain. And then backfilling with some information that I went out to find. It's like, why did I end up with back pain? And I had to figure out which muscles of mine were underdeveloped and which ones were overworking. And I then focused on those, and I don't have back pain anymore. So that's sort of how it helped me. But in the process, Dr. Bruce asked me to figure out how in the world does this technology work, and how does it have an impact on people who are suffering with back pain, and in particular myofascial back pain. And that's how I, in essence, became medical director, as I sat down and spent a lot of time trying to figure out through the World Wide Web how this technology came to be, how it seemed, what effects it has on muscles and other organs or body parts, and then try to implement what's out there in a way that can be proven to be effective for our patients. So it's a personal story. It turns out Sarah has a personal story somewhat similar to that. She got involved with us because of therapy for her back pain, and I was not the provider for her, so I'm really not privy to the whole story, but it was proven to be very helpful for her. So in terms of back pain, the largest percentage of the patients that we see have been suffering for some time. Many have a story very similar to mine, but even worse, in that they've worked with their physicians. Many have worked with physical therapists. Many have worked with chiropractors. Several have been in the process of evaluation by way of surgeons, and that includes patients who've been through the process of having epidurals and other modest interventions. And we've actually taken care of patients who've had spinal fusions or laminectomies, and they're still having back pain. And what that suggests is that nobody has, or I should say, surgeons don't necessarily have the full answer, especially if somebody is having pain specific to the low back and not having what we call radiculopathy, which is a progression of herniated discs to the point that nerves are being compressed and not relieved by change in position or stretches and things of that sort. And those would be patients with severe pain and associated with issues of numbness, say in the foot, and if we're talking about the low back. So that leaves a wide range of patients who suffer low back pain, and the majority of whom have non-surgical disease. And the most common finding is a set of spasms in the muscles that parallel the lower spine and or muscles of the lower pelvis. And we really get into the gluteal muscles, and I don't know what you may know about those. You're welcome to throw out some questions related to that. But what we find is that patients have spasms in the muscles paralleling the spine and muscles of the posterior pelvis, that's really the buttock muscles. And they, in the muscle bed, there are these things called triggers or taut bands. And in essence, what happens is you get an overuse of some muscles, presumably because the glute muscles may be weak. Then you get this constant overuse, and it creates inside the muscle areas of intense focal spasms that are chronic, because when a muscle goes into spasm, there's not enough blood flow because the capillaries or small vessels in that muscle become compressed, and it causes the muscle to go into a state of chronic contraction. And it really can't get itself out of that. And so it's self-sustaining, and other muscle areas are then brought into the fold because there's limited motion that comes out of that scenario, where people end up having added recruitment of ineffective muscles to try to get through the day. That's in a nutshell what we find, and I suspect what a lot of patients have been through, is that they may get some temporary relief from, say, deep tissue massage, but it's difficult for deep tissue massage to get all of the triggers in an area. And so it can be repetitive. The same goes with chiropractic therapy, and I have nothing against chiropractic. In fact, we work with chiropractors as our patients, and we work with their patients if they have lingering issues or pain that's obviously muscular in origin. So anyway, what we find is that patients have persistent pain, and it's in the muscle bed that supports the spine. So I don't know, that sort of gets us started.
Yeah, it's a great overview of back pain. And I experienced that a lot too. I noticed I would guard my lower back, and so I would have pain going up my spine into my shoulders and everywhere.
Right.
Like once we started the treatment, we went up higher in the back, and I was like, wait, that's a spot right there.
Right. So
Yeah.
there's added use of ineffective musculature to try to stabilize the back because of pain. So what I don't know where you want to go next, but I'm assuming people have some interest in what is acoustic wave therapy.
Yeah, well, I was just going to say that if they're just joining us right now, that you're Dr. Tyner and I'm Sarah, and tonight we're here talking about low back pain, specifically low back pain. Right. And now we're going to kind of get into what Primary Bodyworks does with acoustic wave therapy to help end that suffering.
Right.
Yeah.
Right. And again, I was introduced to this because of my own malady. I, as a surgeon, had no idea what acoustic wave therapy was. I was really too busy with other things, but got invited to understand it because of how it helped me and how it was helping other patients that Dr. Bruce was working with. But acoustic wave therapy is utilization of pressure waves that are produced through a amplification of what's called piezoelectric principle. All right, so it's a big long sentence, but what we have are machines that use electricity that turn around and excite quartz crystals that are laid in a handheld probe, and the quartz crystals, when they're challenged with electricity, they vibrate. So it creates a small, very short duration, high intensity pressure wave that is focused so that to a point that we can aim it in an area about the size of a pencil eraser up to 3 centimeters deep, which allows us to get pressure waves aimed into the muscles that support the spine and the lower posterior pelvic muscles. Those are the general areas where people have pain. And the body uses pressure as a stimulus for several different things. And if we take these devices and we were to aim them in a normal muscle, in the thigh or something where somebody was having no pain, and you left these pressure waves aimed at someone, first of all, there would be no pain with that. Patients wouldn't recognize that we were doing it. And in that muscle bed, one of the first things that happens with pressure waves that are focused and aimed in a muscle is it causes a vasodilation. It causes the blood vessels to open up. So if you were a training athlete and you wanted to get ready for a competition, it's actually one of the things done to get the muscle bed ready for active exercise. It's also used in athletes after exercise to speed up the recovery of muscle function. But in our case, what we want to do is use that first principle to improve the blood flow in these tight areas in muscles, which are basically become ineffective because the muscles have contracted and compromise the capillaries into the muscle and prevent the muscle from relaxing. So if you were doing ultrasound of a muscle where there are taut bands or these spasms, you can see these areas where the muscles just really gathered together. And if you were to study it, there'd be loss of blood flow in that part of the muscle. When people are treated with these pressure waves, there's a reversal of that intense contraction because there's an improvement in blood flow. So you start reversing the biochemical environment of a tight muscle, which is increased acid and increased inflammatory factors that are released from a chronic spastic muscle. So the first thing that we accomplish is an improved blood flow. The other thing that's going on in an area where there's these tight bands, there's an acidic environment, and it causes a hyperstimulation of the nerves in the muscle bed, which is why people stay in pain. And when we put these pressure waves over an area, the way that we know we're hitting the right area is those nerves are hyperstimulated, and we're using pressure, and they're pressure receiving nerves. So the patient goes, yep, you found it. So they actually guide us to the area where the problem is. And it's interesting that if you move the probe off an area that's irritable, less than a centimeter, patients they just don't feel anything. So the patient guides us to the area. What we then can do, because of the way these machines are set up, is we can dial back the intensity of the pressure wave to a point where it's tolerable for the patient. So we have an ongoing discourse with the patient. Are we hitting the right spot? How are you tolerating it? And we set a goal of having somebody's discomfort while we're doing this of about a 3 out of 10. 10's enough pain to drive you to the emergency room. 3 is such that, in theory, the patient can tolerate it. Mm-hmm. And what we find is that if we leave the probe there for about 2 minutes, which would be somewhere around 200 individual little clicks that this thing is, that the patient would hear, patients start to say, well, gee, it's not as uncomfortable. It's starting, I just don't feel it. So then we can increase the intensity if that's one of the things we want to do, or otherwise we go find another area that's irritable within a particular muscle bed. And what we end up with after about 20 minutes, if we're treating, say, 1/2 of someone's lower back, is that patients, A, have less pain, and B, when they get up and move around, they go, wait, I'm just not as tight as I was. And part of it is that we've added perfusion to the muscle. The muscle isn't as spastic. And the other thing is that the body, when exposed to these pressure waves, the nerves in that area that are hyperstimulated have a release of some of the neurotransmitters. So there's actually less of a nerve signal back to the brain to tell you that you're having pain. So we create a sense of amnesia in the muscle. If we were to repeat this with a series of these sessions, and I'll tell you that what our average story is, someone come in, let's say their pain in their low back might be a 7 out of 10. And that includes, there's a long list of stories in terms of people having all kinds of different therapies rendered before they see us. But when we're done, the average story is that we take their pain from a 7 and we might drop it down to a 5 or a 4. Which means we didn't get all the triggers, because there can be numerous ones in the muscles of the low back and the upper buttock area. And we will then see them again, and it depends on how severe their pain is, but anywhere from 3 to 7 days later, and when we see them back, their resting pain might have, let's say they've been active and it's crept up a little bit. It might be a 5 instead of the 7 that they were. When we repeat it, their pain drops down to a 3 or a 2. And then when we repeat it, it's down to a 1. And the periods of spasm events tend to reduce as well. So what's going on when we're doing that is we're just continually recruiting new capillaries. And what's interesting, with time, if you keep adding energy into these muscles at the dose that we're delivering, you create a situation where the pain receptors actually start to atrophy. They're just less evident. And on top of that, and this kind of bleeds into other areas. In fact, you may have been involved with our prior seminar, but we were talking about erectile dysfunction. But one of the unique things about pressure waves is that they recruit stem cells that ultimately lead to the laying down of new capillaries. So these muscles that are repetitively involved in spasm, they actually acquire an improved baseline blood flow, so they're less vulnerable to the injury that set up the situation of chronic pain. So that's a long comment.
I know, but it blows me away every time I hear you explain it. All I know is that it works. That's what I know, right?
Well, we've been pretty successful. So what is interesting, there was a study done, 2 parts of this, a study done 20 plus years ago using essentially the same technology in Germany. And they were much quicker to adapt use of this for muscular pain. And they did a study of, I think, 35 patients, and I would say all comers, meaning different musculoskeletal complaints, but a large percentage of them were myofascial pains. And a good portion of those were patients with low back pain. Others were upper back and shoulder pain. And their goal wasn't to see whether the therapy worked. They already made that assumption. But what they did was, their goal was to see, can we cure people? All right? So what they did is, how many sessions will it take to fix these people? And the range was 2 to 20 The average was 7. And they were using less energy than we are and at a little different intensity than we are. So that makes what we're doing a little different. But their goal was to cure people. So they had an over 85% improvement in pain to the point that patients were either cured or markedly better. And the other interesting is some of those improvements continued 3 months after they were finished, which again leads back to the fact that there's less neuroreceptors in these areas of chronic inflammation, and there are new capillaries in the muscles that have been treated, so they're less vulnerable to repeated insults.
That's very interesting, and our machines are much more improved than decades ago, right?
Well, they're more fine-tunable.
Yeah, okay.
All right.
Well, thank you, Dr. Tyner. Now we're going to kind of give you guys a chance to write in with any questions that you may have. And in the meantime, I have some questions that were previously emailed to us.
Well, I'm gonna throw one out. I know this.
Oh, you got one?
Well, no, it's not. I just want people to understand what you went through and what we've seen in other patients. And I say that because we've seen patients come to us. They were in such bad back pain worlds that they were living on narcotics, and managed through pain clinics and such, and again getting intermittent dosing with epidurals and things of that sort. And there was a patient that we took care of. It's sort of the penultimate case. He had had 7 laminectomies, and he was in chronic pain, and he could only sit for about 30 minutes or lay for about 30 minutes. And because of his disability, he couldn't run his business. And when he presented to us, we treated him. And he had inflammatory areas throughout his back, up and down his spine, and in particular in the lower back. And he made an interesting comment while we're doing it. The first thing he said is, "Man, I haven't felt my foot in 6 months." And obviously we relieved some pressure on nerves because of spastic muscles around some of the nerves that leave the spine, and in this case went to the foot. But the other thing he said on the way out the door was, "Wow." And it really reflected just how much better he felt. Now, we took about 6 or 7 more sessions with him to get him to the point where he then ended his use of narcotics completely. And he was able to get back to running his business on a full-time basis, which he had given that authority to other people. So that's a convincing story. And again, I know that Sarah was in a world of hurt and in chronic pain. And I don't know if you want to just say a little bit about it. And this is not really a testimony thing, theoretically, but might be pertinent.
Yeah, I mean, I will tell anyone who asks, actually. And I'm kind of celebrating an anniversary this week, thanks to the treatment I've gotten here. But I was hit by a car, and I was in Duke Trauma Center. Had subsequent surgeries, multiple injuries, and it just kept degenerating. So I ended up with low back pain and other body parts, but my main complaint was probably low back pain. And I was using the other muscle groups that we talked about, the shoulders or upper back, to compensate for that. And I was on pain medication. A very, very large dose just to get through a day, with a pain management clinic on the West Coast. And when I heard about this treatment, I came here, and after the first visit, I just didn't feel the sensations that I had. And I did notice that there was a stacking. So I drove 2 hours every week each way to come here for the treatment. And I did that for a few weeks, and it changed my entire life. It really has. So I knew I had to be a part of the company. And now I've had treatment literally all over my body, everywhere. If it aches, if it hurts, I'm like, oh, can we just put the probe on it for a minute? I think it's wonderful. And I've seen the people that come in here and are in despair. I can feel their pain, you know?
Right.
So it's rewarding to be able to help them.
Sure.
But
sorry.
With that out of the way,
throw it out.
Yeah, and my anniversary this week is that I've actually not had any pain medication in a year. So no opioids at all.
That's cool.
It feels awesome to say that, but yeah.
Right.
Okay, so these are some of the questions that have been emailed. I am going to be checking our links, so if you do have questions for Dr. Tyner, just write them in Messenger, I think is where we're at, and then we'll get a look, okay?
Sure.
Oh, this is a good one. Can this help me even if I have a herniated disc?
Sure. So, first of all, there's a surprisingly large number of people with herniated disc. If you just did MRI studies of 100 people after age 35, and a good portion of them are asymptomatic, which is interesting. Now, as you get older, you're more probable to have symptoms associated with a herniated disc. And what we see is that if somebody comes to us and they do have, say, a foot numbness or a foot drop, that's consistent with severe compression of a nerve because of a herniation or compression. And it's difficult for us to get enough relief of muscles to allow a release of a compressed nerve from a herniated disc in that severe of a setting. At the same time, we've had patients come to us who had been told they might need spinal fusion or laminectomies because they have herniated disc or they have severe scoliosis and or compression within the spinal cord. And we've treated them, and interestingly enough, once we got the muscles around the spine to relax and their pain resolved in the back, they really didn't feel compelled to pursue those surgeries. And it's my belief. In fact, there's some interesting studies out there about patients with herniated discs. A large portion of them happen to have weaknesses in the glute muscles, that's the muscles of the buttocks or upper posterior pelvis. And concomitant with that, they just have this intense spasm of the muscles paralleling the spine up above it, and potentially the muscles in the front of the pelvis, the hip flexors. So if we can get people to get those spasms controlled, reduce the pain in the buttock pelvic muscles, which is actually a surprising amount of what people interpret as back pain. It's really triggers in muscles that are weak. You're trying to use a weak muscle, it's underdeveloped, it spasms more readily, and then you compensate by using back muscles, and they get overused and they get spastic. So if we can break that sequence of events, then even in a setting of a herniated disc, we can get people where they can get improved back mobility and then start doing decompression activities. And that might include chiropractic, but also there are other things that physical therapists can help with to get people in a position where they can start decompressing the disc by body postures. And that includes some yoga type things as a simple way of looking at it. But what our goals are and what we're able to achieve in a large percentage of patients with issues of disc herniation, I'm blocking on the word right now, but anyway, is that we get them out of pain, because most of the time the pain is in the muscles supporting the spine and the muscles right above the back of the pelvic brim. And I'm going to point, I don't know if you can see this, but it's labeled as the back. But in a large percentage of patients, what we find are spasms in the muscles of the upper back glute muscles. And so again, if we get those under control, we're able to help people to the point where a large percentage of patients are not driven to have surgery. In addition to that, we can get a large percentage of patients away from requiring epidurals, injections, and trigger point injections of the back. So,
I actually love that joke about trigger point injections. You're basically just taking a stab in the dark, right?
Well,
I mean,
officially,
I've
yeah.
had trigger injections. I know that they can work, but it is. It's
So to go kind of follow up on that, and I think people who are very practiced at it can be pretty good at it. And but the benefit of this machine is that by sending these pressure waves over whatever area, the patient will tell us that's the spot.
Yeah.
And within 2 millimeters of that's the spot. And that gives an opportunity to be very effective about how we guide this therapy.
Looks like we have this one. I think we kind of.
I want to say one thing about herniated disc.
Yeah.
Here's what I've seen is that if we can get people better, a large percentage of those patients can reduce the other kind of therapies they're going through. If we can't help somebody, that almost in essence makes them a surgical candidate. It's just that it would say that the compression is so bad that they definitely need to either double down and get an MRI or drop the suspense. Once we've eliminated the triggers of the back and they're not better, that disc is so profound that it's not going to get better without surgical therapy.
Right. So how many treatments will I need was written in.
Right. So what I've seen is the longer someone's been suffering, the more triggers they're going to have all up and down the spine and in the pelvic muscles, which are generally weak, and the less duration of problems, the quicker we can get somebody out of this. So if somebody's come to us and they've been in pain for 8 years and they've had a laminectomy or they've had chiropractic therapy and they've been through physical therapy, so forth and so on, I tell them, listen, this is going to take 5 to 7 of these sessions. And that fits pretty well with the data that was gathered 20 years ago. The average is 2 to 20. The mean or the average was 7. And this fellow, who I said, it had 7 laminectomies. He hadn't had a spinal fusion. It took us about 7 to get him to where he was reasonably comfortable, could drive his car without stopping or whatever. I had a patient who we met in South Carolina, strangely enough, at my mother's home, because it was halfway between where she lived and where we are. And she was very interested in this, but she was so bad, she lay down in the back of her car from Sea Island, Georgia to my hometown in South Carolina because she couldn't sit that long. And I treated her and she was a little better. I saw her, I went back to my mom's a week later, we treated her again, and the 3rd week, she's finally said, you know what, I think this is helping. And she had been told before I met her that she needed spinal fusion. And I said, well, let's try it. Who knows, maybe it'll work. And after that, she came to Raleigh and we treated her 3 more times. So that was 6 sessions. And in the end, she started where she was laying down in the back seat of a car. She needed a wheelchair to get around the grocery store. And after the 6th session, she cooked a 3-hour meal for the family gathering for Thanksgiving.
Wow.
And she hadn't been able to do that. And then I kind of lost touch with her. And I called her a few months later. I said, how's it going? She said, well, I meant to call you. I want to know if I can play golf again.
Oh, get out.
Heck yeah, she lived in Sea Island, Georgia. She didn't invite me down to play, if you're watching. Anyway, so ask your question again. I'll make sure I answered it with all.
How many treatments will I need?
So if somebody just threw their back out, and we have people who are competitors, CrossFit trainers and coaches, Taekwondo individuals who just didn't prep their move correctly, meaning activate the glutes before they turn on their back muscles, whatever, with deadlifting and things of that sort. And generally about 3 sessions, and we can get them out of pain and have those muscles working appropriately. Then there's some coaching, and I'm not a physical therapist, but I've become aware of some of this mess. And really try to help them understand that they've got to sequence their moves correctly so they're not using smaller muscles to accomplish what should be the stronger muscles of the pelvis, or the glute muscles. But anyway, so for a lot of our athletes, it's 3 or so of these sessions, and because those muscles are already in pretty good shape and well perfused, it's easier to get a recovery. I will say that as we go through this, as we start getting patients in less pain, we really encourage stretches of the muscles that are too tight, and those are the ones up above the glutes, and really You've got to exercise your pelvic muscles to stabilize your pelvis so you're not asking your back to do what these bigger muscles should be doing. So as we go through this, we really harp on, all right, we've got to get stretches as a daily part of your activity and strengthen the muscles that are too weak so you're not using the other muscles to compensate.
I'm doing my stretches. Okay, we got this question a lot. Is it painful?
Yes. So again, so the basic science is that we're using pressure waves that we can focus right into an area of a muscle that's inflamed and spastic. And the pain receptors are pressure receptors. So we're using pressure to help a muscle that's irritable, and you know because there are pressure receptors in there that are hyperstimulated. So the answer is when we hit an area like that, the response is you found it. And for me personally, the word I used was wow. It's like, yeah, that's it. And the sensation that I had was pressure. And the gal that was doing it for me, I just thought for sure she had her elbow trying to go through me. I mean, that's sort of the way I interpret it. And what we then do is when we find an area, we start dialing back the intensity of the pressure waves. And the technology allows us to basically go where it's barely on to multiple amplitudes above that. And we can titrate it down to a point where the patient is aware of what we're doing, but it's not stopping them from having a conversation. In fact, that's one of the cues. When the patient quits talking to me, I know we've got to back off. And then what happens, again, is we're doing this over a couple of minutes, the muscles start responding, improving their blood flow, and then we can increase the intensity. And on a piece of paper, more pressure is better, but there's a backside to that, and the patient may be intolerant of it. So we treat people, and again, we aim for about 20 minutes in an area, and some people have areas on both sides of the back, so that takes longer, so that might be an hour session for us. But after about 20 minutes, patients have enough relief that, again, the majority of patients can get up, move around, and go, wow, that feels better. And that's a pretty common thing that we hear. And then we would want to repeat that in people who again, are in profound discomfort. And if somebody's really bad, we're trying to get them off a ledge, meaning they're can't decide whether to get the epidural today or tomorrow. We might see them 3 days later. And then as symptoms get better, we space it out to once a week.
That actually is one of our questions that we're getting written in. How often do I have to have the treatment?
Right. So for me personally, because I'm pig-headed and busy and all this other stuff, I had my back treated once and I was impressed. It's like, well, yeah, that's better. I don't know what you just did to me, but it's better. But I had a physical therapist, a massage therapist, and a trainer, all this going at the same time. I went, I'll get it. I'm okay.
Yeah.
So I showed up 3.5 weeks later, says, I'm still needing my heating pad at night. And I'm using a wedge and all this other stuff.
Right.
And so I treated it again, and I was about 80% better. I said, I'm cool. I don't need you. Thank you very much. I'm busy.
Okay.
And I had my third session. It was at least 6 weeks. Or 8 weeks later, I don't know. And it took that final one to get rid of all the triggers, and then I could take advantage of what I had learned, really, I'd say by the School of Hard Knocks, on the importance of a stronger pelvic muscle group and the importance of stretching. And strangely enough, I didn't get that information given to me in a way that I could understand it from my massage therapist, physical therapist, and my trainer who I was paying $100 an hour for. It just didn't come to me in a way that I could make sense of it. So anyway, but if somebody's really bad, we know that after about 3 days, we've lost some of the benefit in patients who are really bad. But on average, a week, and patients notice like they're good for 3 or 4 days, and then their activities or posture or whatever's got them in trouble is still in play, and it might creep up a little bit. So after a week, we treat them again, and then it's like, okay, now I'm better. And they're good for, say, 4 or 5 days. Then we treat them, and then they're good for 6 or 7 days. Mm-hmm. And we treat them, and then we're getting into the point where people aren't really bad. They say, Doc, I think I'm good. Or we might say, well, we maybe 2 more of these, and we'll have you where we need. And the way we know is that we can keep dialing up the intensity of the pressure waves, and the patients are tolerant of it. And I tell people, I get to the max arm machine, which is a 18 level of intensity, we graduate them.
Yeah.
And by the time we get there, they're already telling me, yeah, I'm sleeping better. I don't know. So for me, this happened not long ago. I was reaching under my car seat and I pulled out a body vest thing, a Velcro thing, and in it was an ice pack. And I thought my wife had put it in there, and I called her. She said, no, dummy, that was yours. You used to drive with that thing. But, you know, you just find that you need less fixes for your pain as we go through it. And so the once a week interval works for most people. And again, the average in the study in Europe was 7, and that's all comers. And what we see is somewhere around 4 or 5. And when we get there, we've got the majority of our patients are comfortable. They are starting to hopefully do some of the exercises and the stretches. And then we sometimes see people maybe once a month, or we might see them in 3 months, or we just don't see them anymore.
Yeah.
So.
Which is kind of our goal, you know?
Right, sure, no.
Just make it better. Don't come back.
Right. No, I used to tell people as a surgeon, you know, I'm the last person you want to know.
Yeah.
Right?
Yeah.
You don't want to know a surgeon. Right?
I know a lot of surgeons.
Well, we're all nice people.
Yeah, they're all very nice. Let me see. Oh, this is actually a really good one. As an ex-college athlete, I have random tightness, which leads to muscle spasms. Can you treat the specific issue? So it sounds like some abuse in the past to the body.
Yeah, I suspect. Well, I mean, we see athletes who overtrain, and a lot of athletes are a little pig-headed and may not do stretches. In fact, David Coggins, the world's greatest athlete, stopped competing because he forgot to stretch, and every muscle he owned turned into a tight knot. So, you know, I think it depends on what your athletic endeavors are, but if it's an issue of muscle pain or tendonitis, which is some of this stuff, but in relationship to low back, it is rare for us not to be able to get people to a point where they're not having spasms. It is really very rare.
Yeah.
Coupled with that would be talking about technique if they're still trying to be athletic. And in particular, and people that work with me know that there's one muscle in particular that I hound people on, and that is this thing called a gluteus medius.
Yeah.
And we've had people who are CrossFit coaches come in here with a particular weakness in the gluteus medius. And that in turn leads to a breakdown in technique when it comes to deadlifts and things of that sort, and then they hurt their back. So we test for that, and we stimulate that area to see if they have triggers in that. And then once we get triggers and therefore pain out of muscle beds, it's like, hey, you've got to make these muscles stretched, or you have to get them stretched so they're less taut on day-to-day basis. You've got to train this muscle, and I say it sort of just like that.
Yeah. You
want your glute medius to be the strongest muscle you own on your body, because it is the linchpin to issues of low back pain, and it extends down to issues of arthritis of the hip, arthritis of the knee, plantar fasciitis. And listen, you'll never get me to stop talking about that particular muscle. As it turns out, for me personally, it's the muscle I didn't even understand. I was a long distance runner in college. I competed with guys trying out for the Olympic marathon. So I was very competitive, but I never worked that muscle. And my whole surgical career, I had back pain. And it peaked when I quit. Well, what happens for me now, I have a 41-pound foster daughter, she's now adopted, who only uses one arm that far. That's it. And my job is to pick her up, and I carry her on my shoulders because she loves it, and she can't hurt my back. And ultimately, that's my goal. And the way I do that is practice, stretching my back and getting my glutes to fire first when I lift up something or get myself out of a chair or whatever. So I don't know that my back is bulletproof, but it's a whole lot better than when I first ran into this machine.
Right.
So.
Actually, I was thinking, I don't know how many of our clients are currently watching us right now, but I was thinking what a fun game it would be if you know Dr. Tyner, how many times has he talked about that One gluteus stretch, right?
Well,
I know we get it all the time with you.
Yeah, well,
it's important.
It saved me.
Yeah.
So there you go.
So. Yep. Okay. Oh, this is a two-part question. How long do results last, and will I need to come back? I think we've kind of touched on those pretty much.
Right. So I think we don't see a lot of patients back. We occasionally will have patients who will kind of fall back into a state of partial discontent. And really what I do is the first thing I do is test their glute function. It's kind of like an insult to them. And but the largest percentage of patients, we get them to where they're pretty comfortable. And I'd say our recurrence rate is maybe 10 or 15%, I'm guessing. We haven't been able to track that cleanly, but we do occasionally see patients who have temporary periods of recurrence of pain, and most of them have gone back to some activity where they've really overused a muscle group, and almost always coupled with it, they're not doing stretches and they're not strengthening, in particular, this gluteus muscle group. The world is such that if you're sitting, and a lot of people are in that's their world.
Yeah.
When you sit, your gluteus muscle goes to sleep. And when you stand up from that sitting event, you turn on your low back to stand up. You don't turn on your glute if it's asleep. And it's just repetitive and it's repetitive. So what way I see our job is to get people out of pain and then insist on them and encourage them and coach them, both with these kind of comments I'm making, but also show them exercises and such. And we send a huge stack of videos that have been garnered from people who I think are very good at communicating what the problems are, so that they'll have some basic understanding of how they can protect themselves.
Yeah.
The other thing, as I said, is going backwards, is that we change the pain receptors in those areas, and we set up a scenario where that muscle is liable to have better blood flow at baseline.
Right.
So that it's less vulnerable to the process that got them in trouble.
Right. And you know what, I do see a lot of clients coming in saying, you helped my one problem so much, can you try this one? Like they've had wrist pain for 20 years.
And sort of couple that, say, well, I didn't even know I had pain over there because I used to have pain over here.
Yeah.
So they come in and say, well, my shoulder's bothering me now, not my back.
Yeah.
And okay, great, we fixed something.
Yeah.
But then they're more aware of another.
That's how I got my whole body treated.
Okay.
Let's say, okay, so this one is actually written in, it says, my doctor said I have a mechanical issue. Will this treatment help that? Mechanical.
So a mechanical issue, if I were to first impression, I'm assuming that would be, again, related to herniated disc,
right.
Cord compression, degenerative changes, degenerative disease of the spine, so forth and so on. So I would say the odds are the answer is yes. And I would say that with an 80-85% probability of being right.
Mm-hmm.
And you wouldn't know unless you try. And the benefit of this is we can't hurt you.
Right.
All right? This technology does not allow us to do harm, because the intensity of these pressure waves are such they're really dialed in fairly well for the soft tissue structures that we're treating.
Right.
The original way this energy came to be was busting kidney stones. That's called lithotripsy. And if you tried that kind of energy in a muscle, you might injure the muscle, and for sure you could injure a tendon. This is a more refined, lower intensity pressure wave than that. So with that in mind, we may not help you if you've got a disc that's so bad that you can't feel your foot and it's in pain. We may not be able to help you, but we will not hurt you.
Right.
All right?
Give it a try. Okay, this one is actually very similar to some of the ones we're getting emailed in. Will my results be permanent?
Yeah, so that goes back to what I was alluding to. I mean, for me personally, the answer was yes, and I had 3 sessions, so I wasn't too bad. I never had an x-ray of my spine or any of that sort of stuff. If somebody had, let's say they had 4 herniated discs, and they had scoliosis of the spine, which is severe curvature of the spine, which is chronic, been going on since they were age 10, it's going to be harder to rescue those. But I have a patient that I'm seeing right now. He's in his 5th one. He's skiing right now. He's skiing in Jackson Hole, Wyoming. And when I met him, he would not have been able to ski.
Mm-hmm. I spoke with him while he was there. I don't know why he called in, but the powder was really good over in Wyoming right now, making us jealous.
I have a little envy, but just the same. That individual has scoliosis of the spine.
Yes.
And his issue is he has all the muscles around there. He's using them in an irregular way. So we've helped him. We're not going to cure his scoliosis, right?
Right.
And we're probably not able to rescue completely somebody with 4 herniated discs of varying degrees. If it's on the more profound side, we can get rid of pain in the low back. But in the largest percentage of patients who are suffering from back pain, if we can get the triggers out of the muscles and get them to strengthen the appropriate muscles so that when they stand up or they sit down or they lift their kids or if they're reaching in their car to grab something, they don't set it back off into mode of spasm.
Right. Those mechanisms, right?
Right.
Lift with your knees, all those things.
Right. So activate your glute medius, so you use your hamstring, so you're not using your back.
Is anybody out there counting this? Because I just gotta know. Actually, some questions are rolling in, and I've got this one. Diane asks, what's the price per session, and do you take insurance? And the simple answer is, right now we do not take insurance. We kind of are working on it. The initial visit, it lasts about an hour. You'll come in and meet with one of our therapists, talk about the pain you're experiencing, duration, put a number on it, and then you would go into the treatment. So it's about an hour. That visit for the initial is $99, and then the subsequent treatments, half an hour is at $99, and the hour is at $169. And as Dr. Tyner alluded to earlier, we have package deals. So it just kind of depends on what you and your therapist talk about for your progress going forward.
I will say it's interesting in Europe, this is a covered process because they have confidence in the outcomes. The United States, has been slow to adopt this idea, and insurance companies have been particularly slow about it. It's interesting, if you compare the cost that we create by doing this and compare it to the cost of, say, an epidural injection, which much more inexpensive, and I would say greater in terms of prolonged benefit. But insurance companies are hesitant. It's one of the reasons I'm not a surgeon anymore.
Yes.
I'm glad to have left that field, but go ahead.
Yeah. Okay, so looks like we have one in here. Do I need an MRI or an X-ray for treatment?
No, I didn't.
I didn't. I had them, but I didn't bring them to my appointment.
So an MRI is a good baseline. An MRI does not tell you. In fact, the problem with MRIs, the way that they're generally interpreted, they are not focused at the muscles. They have the ability to use an MRI to analyze what's going on in the muscle. It's just not done on a regular basis. And ultrasounds can be done to identify triggers in muscles. But again, it's not done on a regular basis. MRIs can tell you, say, the degree of herniation, the number of discs herniated, the degree of spinal stenosis, scoliosis, all that. It still is not a predictor in any clean way as to A, whether you'd get better if you had surgery, or B, whether you get better if you have our therapy.
Right.
Because a high percentage of patients that have spinal fusion still have back pain. In fact, we treat those patients because we still find triggers in the muscles of the low back and the upper posterior pelvis. So, but it's helpful information, and you never should discard good information. But again, going back to the lady I met from Georgia, she had a horrible report on her MRI and her spine x-ray describing the degree of degeneration that she had, and she'd been told she needed spinal fusion, and she was in severe pain, and we treated her, and for what it's worth, we did not repeat any of those x-rays because she was out playing golf. So, it doesn't hurt. It might be a predictor of our success. I think you do have to put that into your line of thinking, and you have to understand if somebody has a well-defined neuropathic, meaning the nerve root and the things at the end of the nerve root, the foot, and talking about low back, if it's that severe, it lowers the probability of us helping. But what's interesting is that, like the sciatic nerve is compressed by muscles in the buttocks, the piriformis muscle, and it's an area that we go chasing when we're treating, quote, low back pain, and somebody that has, quote, sciatica, and we actually can relieve sciatica under those circumstances, and I would say that represents 40-50% of people with sciatica. It's actually not a compression because of a disc. It's a compression because of a muscle.
Right. I am trying to get to everyone's questions, but I actually just noticed the clock. And I could stay here all night talking about this. I don't have anyone to run home to, but Dr. Tyner does. So I think we're going to call it here, and that's going to be the end of our seminar for tonight, and I'll let you get going.
All right.
But thank you, everyone, for joining us. And if you have any questions, just call our office or schedule an appointment. Come on in.
We can try to get some of the answers online as well, or some of the questions.
Right, we could do that as well. But don't forget to follow us on social media, because I think we're going to do some more of these seminars. Right? Are you in for it? I think I got to feed him dinner. I don't know.
I got plenty to do, but yeah, it's okay.
We'll make time. All right. Well, thank you, everybody, and I hope you have a great night. Let us know if there's anything we can do to help. Okay? Bye. Let me just grab this.